So welcome to interprofessional collaboration with health risk, home evaluation, and safe mobility intervention. And I am Celinda Jansen. I'm a faculty member in the Occupational Therapy Department at the School of Medicine and Health Sciences at the University of North Dakota. And I want to thank my two participants who also helped with the case study analysis. This is Virginia Colbert. She is my mother. And this is Andrew Jensen. He is my son and he is an RN. And so both of them helped to create an exemplar for a home evaluation. So thank you for both of you for your contribution. So we'll do this warm up, which is shared with my mother, Virginia's permission. Virginia is an 85-year-old retired teacher living in a small town in a rural Midwest area. She had a few falls and is trying very hard to stay safe. Falls in the tub or shower are the most concerning due to the water. She is on medications for migraines, arthritis, blood pressure, and atrial fibrillation. She experiences rare episodes of low blood sugar. Cognition and affect are normal, except during migraines or episodes of severe pain from arthritic nerve impingement of her spine, when she has said it's hard to think or find the right words. So we're going to be using this information to connect to the 4 M's in just a few minutes. So how many of you in this past year have seen a similar case scenario that made you think this person is presenting for risk factors for falling? Could you please, you can either push the reaction tag with your thumbs up or a yes. How many of you have seen typical scenarios like this? Or you can type in the chat box. Yes, I see thumbs up. There's a reaction tab on the bottom, and you can give me a thumbs up if you have seen a similar case scenario where you recognize many fall risk factors. Okay, thank you for sharing. So a few of you. Well, let's take this and match it up with the 4 M's. The 4 M's are the key areas to address with geriatric care. We'll match the fall risk factors from Virginia's case scenario to the different 4 M's. So for the first one, what matters? What is most important from her case study? She said she had a few falls and is trying to stay safe, and falls in the tub and shower are most concerning. So that was one. So that has to do with what matters when we look at the 4 M's of geriatric case or geriatric care. So what else falls under what matters? Meal preparation is important to regulate her blood sugar. So if blood sugar was the problem, it's going to be really important that she have regular intake of meals. So that falls under the what matters category. How about mentation? What did we say about Virginia for mentation? Well, we know that she has pain episodes that impact her cognition and affect at times. And then how about the medication? She's on quite a few medications. Pain medication can make people unsteady. And there's some others. And we also know she might have some cardiac things, so blood pressure might be an issue. And then under the mobility, we know there's a history of several falls. And we know that arthritis can cause unsteadiness. So if we make sure that we address all 4 M's, we can adequately cover all of the main issues in Virginia's case study. So the objectives for this is that we'll be able to screen for risk factors that can lead to falls. We will identify essential elements to include in a home evaluation to assess fall risk and intervene with safe mobility strategies. And we'll do that simultaneously because those two things happen concurrently. And then we'll use interprofessional collaboration to create interventions for safe mobility. So our overarching statement of need for this particular presentation is that, and Rebecca, you said it so well, this is such an important topic, and it's because of this. Most older adults want to age in place. Therefore, there is a need for interprofessional collaboration with fall risk home evaluation and safe mobility interventions. So quickly, a few facts about falls. We know that they're a leading cause of injury among older adults. 1 in 4 fall each year, but almost half of those falls are unreported. We know that the death rates of older adults who fell have increased 30% between 2007 and 2016. And we know that in 2015, the total medical costs were $50 billion. So it is a very serious need. And really every older adult we treat, we really should be addressing falls. This is a very nice diagram that one of our occupational therapy graduates created for me. This is the impact of a fall. And you can start anywhere on this wheel. And so I'm going to present this one, the impact of falls. And then in a little bit, I'll talk about the opposite one, the impact of participation. So we'll start here. I'm just going to start in the fall. And a fall for an older adult will cause, in most cases, fear of falling. This fear of falling decreases their participation in ADLs, which makes them not eat or drink. So for example, they might not want to eat because they don't feel safe with mobility in the kitchen, especially if they're using a walker where they have to keep their hands on the walker. Or they won't want to drink water because then they'll have to go up and participate in toileting. And so then they get dehydrated, which can make them weaker. And then they don't go out and socialize because they don't have that confidence from the fear of falling and they're weaker. And my tab is not showing. And so if they're not going out in to participate socially, then they end up being lonely, and loneliness keeps them in their house, and it can cause additional weakness, which contributes to another fall, and then the vicious cycle keeps going. So what we want to do is assess for all of these risk factors with falls, and then help them engage in participation of meaningful activities. So there are other fall correlations. Anyone with no physical activity or functional impairments, especially for stairs, dressing, and bathing, and community mobility. The CDC puts fall risk factors into 2 categories: intrinsic within the person and extrinsic, which is in their environment. So of course, age, which we see with Virginia, 85 is a risk factor. Previous falls, we saw that in Virginia, she had previous falls. Muscle weakness, we've seen that because it's hard to keep the muscle strength when a person has sore joints. Gait and balance impairment, that's intermittent, yes. Poor vision, her vision is good. Postural or hypotension, that might be indicated in Virginia's case periodically. But we know that for her, it's lower blood sugars that happen. And chronic conditions, which she has, chronic condition, and fear of falling. And she has a little bit of that, not too bad. Then the CDC puts them into extrinsic factors, such as everything in the environment: missing handrails, poor stair design, missing grab bars in the bathroom, poor lighting, tripping hazards, slippery surfaces, medications, improper use of assistive devices. We will address all of these extrinsic factors in the videos that will show of a home eval with Virginia. So other things to keep in mind is cognition and attention. So moving through the environment is a complex task, and our automatic reactions decline as we age. So there is a loss of automatic postural control to correct balance as one ages. And then if we add a task So they're thinking about their balance and doing a cognitive or physical task, or transitional motions or sequencing. There's a trade-off. And so, for example, one time I was working with a lady and assessing her balance, and she was actually walking quite well without her walker, but I did have a transfer belt on her. Somebody walked by her and said hi and waved to her and said her name. And she paused and looked up and waved at this person, and she suddenly lost her balance. She didn't go down. She just had a little slight balance loss that she caught herself. So that dual task is what we really want to focus on. These are the reasons that people have said that they fall. And it almost always happens when they're doing a task, usually in their own home or a community. So pay attention to the dual task. I fell while reaching for my shoes. I tripped on the corner of my bedspread while making it. I slipped while stepping into the tub. I raced to answer the phone. I tripped on the threshold while reaching for the mailbox from the doorway. I just went sideways and down while getting something out of the oven. And I missed the step while bringing in the groceries. So you can see this dual task is what triggers the fall for a lot of older people. And I'm sure a lot of you can relate and have seen similar types of comments from the clients or patients that you have seen. So another thing I like to pay attention to is the stepping strategy. And this is really important for balance, really looking at balance and writing reactions. So the first thing that happens for a vestibular reaction when there's a slight loss of balance is the ankle strategy. And if you all were able to stand up right now and do this, if you were able to, go ahead. But if you start losing your balance slightly backwards, what is the very first thing that happens? Your toes go up. If you slide backwards, your toes are the first thing. So we have to have that ankle strategy, the range of motion and the strength to raise those toes or to go to the side and use those ankles sideways. Then it's the knee strategy, then the hipping strategy and the stepping strategy. If we have physical therapists in here, Emily, feel free to jump in if you want. I know you're here. But it's really important to pay attention to those particular writing reactions. And this is why the famous Stepping On Falls Prevention Program has specific exercises for the ankle, knee, hip, and stepping. So those are specific exercises included in that fall prevention program. But it's because of those exercises help to maintain those writing reactions. And you'll see people doing things a different way while they're doing a task. So in this first image, this is what I see very common is people will put their walker aside and reach for something. So then I spend a lot of time working on proper walker placement while reaching, especially in the refrigerator. So older adults will fall more often when they're challenged with postural need plus a cognitive task, and the risk will increase, the risk of falling will increase as the cognitive task becomes harder. Therefore, where do all these cognitive tasks occur? They typically occur in their own home when they're doing meaningful tasks, such as home maintenance or meal preparation, IADLs, ADLs. So the home evaluation is done plus the intervention. It's not about just going in and removing scatter rugs by scanning the environment and looking at changing things. The purpose of the home evaluation is to assess and intervene simultaneously with the person while you're having them actually do the tasks in each room of their home. Syntax matters. So here's another little thing I learned from experience. We have these falls prevention programs, which you'll hear me saying that word quite frequently in this session. But when I'm out with the older adults, I try not to say very much about falls prevention And if I do, I will quickly transition to safe mobility. So what I found out is it seems like it's very anecdotal, just my experience. It seems like when they're saying falls prevention, they're thinking about a fall and they're actually at a higher risk of falling because the body does what the brain is thinking about. It's like shooting a basket. If you think you're going to miss, you actually will miss. If you think you're going to make it and are focusing on making it, then make it. So if we transition quickly when talking to older adults to safe mobility, then they think about safe mobility and then they do safe mobility. And I have seen a decrease in falls when I use safe mobility more often. But that's anecdotal. There's no research. I couldn't find it. So now I said I was going to show you a second diagram. The first one was the impact of falls. Now this one's the impact of participation. The focus of this home eval is to really, and the intervention is to really facilitate participation. So we're doing something. So you can start again anywhere on this wheel, but I'm going to start with the word participation on the left. If somebody is participating, then they have confidence in that activity or self-efficacy, and that actually prompts them to engage in more occupations such as cooking, eating, drinking, going to the bathroom, going out and about, and that facilitates proper hydration and nutrition, which keeps them strong, and the hydration keeps all their nerves and muscles working well. And that engages them in social participation where they can actually leave their home, which increases more confidence and strength, which also increases ongoing participation. So you can keep going around this room. So that's what we want to facilitate with this home eval and safe mobility interventions in the home. So the home eval is really the more accurate evaluation for identifying risk factors for falls, because you're seeing the actual person in their own authentic normal environment where all their normal supports and barriers are, and you're looking at them doing their normal activities. So I've done a few simulations, like if they were in the nursing home, and they didn't work very well. They're okay for training and therapy purposes, but I was actually working with a young healthcare provider who was non-weight bearing, and we figured out a way that she could transfer to the tub by transferring to her strong side. And we practiced in the nursing home and everything was going great. I didn't even know if I needed to do a home evaluation with her because she did so well. But I thought, oh, I better. So I went to her home and there was no place to turn the wheelchair around so she could transfer to a strong side. So I found out that in her setting, she wasn't able to transfer very well or safely. So we processed and problem solved a different way of doing the transfer. And we ended up having her back her wheelchair in and she was able to do it adequately. So it was a good thing we did that home evaluation because it was a more accurate assessment than anything we can find in the nursing home. There are a few guiding principles for the home evaluation. Many older adults will decline a home evaluation to address fall risk and safe mobility because they're afraid that people might try to put them in a nursing home. They don't know that that's illegal. You can't put them in a nursing home against their will, especially when they're cognitively impaired, but they don't know that. So I really try to change my syntax. So the first few times I wanted to do a home eval, they declined. And then I changed to collaborative communication by asking them, well, what is your goal? And if they were in the nursing home or hospital, they would say, well, I want to go home and stay at home as long as possible. And I'd say, if going home is your goal, then I'm the person who's going to help you get there. And I'm the one who's going to help you stay there as long as you want or can. And then they instantly trusted me. Then I'll say, we typically do this by doing a home visit with you before discharge. So we can suggest ideas that will make things easier and safer for you. And once I switched to this strategy, I never had one person decline the home visit. So home eval for the work for this seminar, home visit when talking to the older adults. So interprofessional collaboration, who can generate the referral? Well, really any of us can, any of us should. And this is really valuable. This is where I really like this, having the social workers involved, because they're really the orchestrators of case management in home and discharge planning. So they can look at these home evaluations and make these recommendations to the team, get a doctor's referral, and make sure that the referral can come from the doctor, DPT, nurse practitioner, physician assistant, anybody who can write that referral. And then who can do the home eval? Any skilled professional who has trained in physical cognitive task analysis and environmental analysis. Typically, we will see OTs, PTs, nursing being the primary home evaluators, but many others can do it as well. Even the doctor can if there's time. If there's limited providers and the doctor is willing to do a home eval, that would be kind of neat. I would really like to see that. So, and then all interprofessional team members can review the home eval summary. I had one facility nursing home that I worked at, they wouldn't discharge anybody home, and the county nursing screening team wouldn't even start their screening. The social workers didn't start the discharge planning until they had the OT home eval and was able to read it and knew what the recommendations were. And I was really happy to see that. I thought that was really nice teamwork. So I do like to see a pre-home screening done, because sometimes those screening tools tell me what to focus on during the home evaluation. So some of the screening tools, which is a small list, but kind of picked out some of the good ones, really good ones. So a lot of us like the BEST test. There's also another version called the mini BEST. And the reason I like this balance test is because it includes writing reactions that we described earlier, such as the ankle, knee, hip stepping strategies. I like to go to physical therapy for the functional gait assessments because they are the masters on gait. And strength tests, most of us on the healthcare team can do manual muscle tests. Blood pressure, a lot of us can do that. I do like to go to nursing in particular, so that we have an assessment of their blood pressure changes from laying, sitting, and standing. History of falls is very important because it tells us the details of what may have been a contributing factor to the fall, and then I can hone in on that in the home eval. And then the fear of falling scale, or fears efficacy scale, is really important because, again, when it's over, well, I'll show you that in a minute. And then also looking at the medications and the side effects and the schedule for when you take those medications. So here is an example of some of the things that are covered in the falls efficacy scale on a scale of 1 to 10, with 1 being very confident and 10 being not confident. How confident are you that you do the following activities without falling? And if they have a not confident number for taking a shower, then I might spend more time on that during the home eval, with doing more repetition for safe tub and shower transfers, for example, which you'll see in the videos that I'm going to be showing. A good theoretical model that is interprofessional in nature is the Ecology of Human Performance by Winnie Dunn. And this one helps you, it helps to organize your approach to the home evaluation by looking at the person as they engage in specific tasks in each part of their environment to assess their overall performance range. Maybe they perform really well in this setting with this task and not as well with this setting and that task. And then these are just a few preparatory things. I always bring a transfer belt and use it when needed. I did not need it with Virginia because she's already doing these things independently, and I had a good knowledge of that before doing the home eval. Cell phone in case there's an emergency, gloves, hand sanitizer, mask. You know, they're kind of common sense. But I'm always ready to give contact cards, standby system, and that's it. Okay, so now I'm going to stop sharing this. I'm going to go straight to the videos so that I don't have to go back and forth. All right. So we're going to show some videos and hone in on a few key things. In this particular video, you will see this is Andrew. As I said, he is an RN, so I was really happy to have him in here. And this is a common sense thing, but it's often overlooked or forgotten. So pay attention to Andrew's therapeutic communication in this video of Virginia.
Do you mind if I move this chair out of the way a little bit? Make it a little wider for you?
Yeah, that'd be great.
Okay.
Thank you.
You have more space.
Yep.
So we are just exemplifying, it's a very simple thing, but it's such a core, most important thing of doing that is collaborating and asking with everything that you do. Now, in this next video, it exemplifies, this next video exemplifies how to concurrently do the assessment and the intervention simultaneously while they're actually doing the task.
And one way you can do it too, if you can open the door a little bit and then it'll fit in like this,
Okay.
then you can put your items in the bag there.
Yeah, okay. That works better.
That way you have it
Yeah,
to support all the time.
thanks. That's helpful.
So you notice that she has that
And one way you
rocker. And she's really liking that because it's much easier to maneuver and it's less of a tripping hazard for her. So he's kind of demonstrating ways, and we'll come back to this video again when we're talking about different strategies in the kitchen. So I'm going to go through and show each one. Now on this next video, pay really close attention to the tripping hazards as she's maneuvering in the bathroom.
This is the tightest that I go through right here. So
Right
do you
here?
want me to sit on the toilet, did you say?
Sure, if you don't mind.
Oops. Find my shoelace.
it's a good idea to have those bars.
Yeah, they're handy. I don't know what I'd do without that. Even at the lake, we had those.
So in this one, Andrew is reinforcing something that she's already doing. And that's another good intervention, is to help her maintain what she's doing well already, to make sure she keeps doing it. Now we're going to be going into the bedroom to illustrate safe mobility, and she's going to showcase her system. So this is where habits and routines are really important to use when making any type of recommendations for them.
Okay.
So usually when I do a home evaluation, I actually have them get in and out of bed, and I ask them to unmake the bed and get into the bed, because a lot of times the sheets can get tangled in their feet. And it's actually very hard for them to get in and out of the bed. So it's not good enough just to lay on the bed, but it's important to lift the sheets up. And the other thing is with Grandma, she did better sleeping when she had satin pajamas or a satin nightie, because it slipped and it allowed her to roll over better in bed.
Okay.
So, do you want to?
You want me to show you how
Yeah.
I do this?
Yeah, would you mind?
Okay.
Come here, puppies.
At night, I get my whole bed arranged before I ever come in, you know, so it's all set. Can you move, Harmony? I put those pillows over there. I pull this down. Fold its way back. This is for my feet when I get into bed. So I sit here, turn the light on, sit here. I'll have my pajamas on and take my shoes off. I put these on over the top and then I'm all set for bed. And I do this ahead of time, you know, so that everything is all arranged. All I have to do is get into bed.
And you used to have a bar that I gave you that went between the mattress and the box spring.
Yep.
And it was a repositioning bar after I think you had your knee surgery. Is that correct? But you don't need that anymore.
No, if I need it, you know, I have this.
Okay.
And I can grab that if I need it, but no, I just plan ahead. Have my pajamas on, so when I come in here, I have my pajamas on, and I put those slippers on before I get into bed, and just.
So you can get your feet up and underneath the covers quite well. That's good.
Yeah.
And when
my bed raises, I can raise my head.
That's nice.
And I can raise my feet.
Great.
I don't use that much, but you know, if I feel like it, I do.
Good. So you don't need the repositioning bar. Was it helpful?
Yep, it was helpful
originally
then.
when you needed it?
Yeah.
When you had your knee surgery?
Yeah.
Okay.
But now with this new bed, I don't know, I don't seem to need that.
Okay.
Okay.
All right, Andy was having a little fun with our camera showing the high school graduation pictures. Thank you for your patience. Okay, so there's another part of the bedspread that's really important to pay attention to, and Virginia's going to explain this to you, that we don't always think about, and I never thought about it until something bad happened.
So Virginia, how did your mother fall and break her hip?
Well, she tripped over this bedspread that was hanging down. And she caught her foot in it. So it's not a good thing.
All right, so that one is really important because the questions actually help steer the client to the danger hazard. And if they can identify the dangerous hazard first, then they can own the solution. And then we'll end up getting better adherence. So now we're going to spend, remember we said in the beginning of this case that showering and bathing were the most concerning, which is consistent with most older adults. So now we're going to spend a little bit more time in the bathroom. Pay attention to your rugs, the sizes, and the transfer technique. Virginia's going to show us how she gets into the tub. Pay really close attention to the placement of the tub bench seat and also where she puts her left foot.
Virginia, would you mind demonstrating how you get in and out of the tub and use that tub bench safely?
I have to get rid of these things.
So you have a nice tub bench.
And I have this on the floor.
Oh, good. So it's not slippery when you put that on the floor.
Now,
And you can reach down there and put it down, so that's good.
and this goes here.
That rod. And it goes in the back. And it comes in the back. Then the other side.
And I hang on to here and here. Now,
Do you step over?
yep,
Oh,
that's why I take a shower now.
okay.
You can hear.
You have a handle there. Okay. Okay. So you're holding onto the seat and the handle when you step over.
And
Okay. Thank you.
Okay, so that one I thought was a little bit unsafe. So now we're going to do something to enhance, and this is where you'll see me adjust the tub bench, the height, and the positioning, and then you'll also see me do some patient education by demonstrating and then doing return demonstration in the next video.
Oops, wrong way.
mm,
So we can actually make this a little bit higher. So you don't have to sit down. This would be good for people that have weak glutes and weak quadriceps. And yours was actually a little bit tippy.
yeah, it was, wasn't it?
Yeah, so what I
I
think,
can't remember that it ever.
I feel like I
that
want-
before, but-
yeah, I feel like I want to bring this side up a little bit higher.
Oh, so it's,
It's a little higher.
okay.
Now you have to set this fairly far back. Otherwise, there's no space to get your foot
Right,
in front of this rail.
yeah.
Now
I think
there-
I've had it back further before.
Are you video? Thank you. The tub benches I like are the ones that come over the edge. The only problem is when it does that, you can't get the shower curtain inside to keep the water inside. So if this comes out farther, you almost have to sit on it after you get in the shower. But if it's a little bit higher and you can hold on, it'd be nice to have a rail right here on the right. But if it's higher, you can sit down like this, and then you can scoot back, and then you can, the farther back you scoot, the easier it is to get your feet over the edge of the tub
Okay.
between the chair and that handrail. And then you can go this way. And I think it'll be easier having this a little bit higher.
Mm-hmm.
And then again, you get your feet out and then you scoot to the edge of the tub like this.
Okay.
And then you can stand up.
I did have
So you
one.
can stop it.
Okay, so that's a demonstration of how to do it safely, and then in the next video, then I'll have her do a return demonstration. So this is really important for interventions.
There you go. Now you have a little bit more space because the chair is higher and it's farther back. So you have a little more space to get your foot in front of that handrail if Harmony wasn't here. How do you feel about that?
I just,
You need a rail right here, don't you?
yeah,
I think you do too. I would like to see one,
Right, I am.
maybe another one of these.
That would work.
Let's get you another one of these.
But I don't take a shower anymore, so I go downstairs.
Okay, so she says she's now going downstairs to take her shower, so that's my cue that we really want to take a look at the stairs. Now pay attention to how well she's concentrating on this one. She's not talking during this one. And pay close attention to the double handle.
That's really nice to have those 2 rails.
It is.
And I had a gentleman that had rails on every wall of his house. And it was a small house, so everywhere he went, there were rails. I really like that.
All right. So we get downstairs and then we look at her mobility as she gets into the shower.
So when I get in the shower, I hang on to this. And I steady myself here. And I step in, I hang on to this. And I'm all set.
Do you sit when you shower usually or stand?
No, I stand.
Okay. Okay.
All right, so she was using the one handrail, but she was grabbing onto the faucet with the other hand, so she might really benefit from a rail in there. So now we'll look at the low toilet seat in that bathroom downstairs. So pay attention to the rails and what she might need in particular. And she's got arthritis in her hand, so look what she does with her right hand.
And when I sit here, I can, it's hard to get up because this toilet isn't as
See that?
high as the one upstairs.
So how would you feel about a little bit of a raised toilet seat down here? You don't really like those, do you?
Oh, it's so hard to keep it clean.
Yeah.
I put my finger in here as an anchor,
Okay.
and I hang on to this,
Mm-hmm.
and hold myself up that way.
But a raised toilet seat would really be a little bit better if you could keep it clean.
Yeah, we had
Okay.
one like that upstairs. It's better to have a raised toilet.
Yeah. So it would be nice to actually have somebody install a higher toilet, which they do have. I mean, they have higher ones.
Yeah.
So you'd rather have that than a raised toilet seat.
Yeah.
So this targets adherence, ability to follow through if it fits their preferences, which is so important. So Andrew is an RN, I'm an OT. Who else could do a home evaluation? Who else could do this? There are actually a lot of professionals. Anybody who can really assess the person as they engage in specific tasks in each room, as long as it's very, very safe. And his therapeutic communication really enhanced a sense of control, which correlates with ability to follow through or adherence to the recommendations. In the kitchen, she had a firm bag in her triangle walker to transport items. Now, some people that have a regular walker with 4 legs, they might have a walker tray that helps them transport items. Other people I've worked with have used a cookie sheet to slide items across the counter. That would not have worked for Virginia because she has other things on her counters and different leveled counters. And then beverage holders, carrying beverages is hard because it spills, so I like to recommend heavy, wide base beverage holders with covers. And in the bathroom, we noticed there were risks. There was a rug that was slipping, and there was items on the floor. But we have to be very careful how we address that, these rug issues, because they're very important to people. You can't just say, oh, you need to remove your scatterboard. We need to engage in the discussion. That dangerous bedspread, it was so good that we asked Virginia about it, so she could identify the danger, and then she can actually strategize a way to minimize the danger. So maybe we could talk about tucking that corner in between the mattress and the bedspread. But, you know, it would depend on how it looks. In her bed, I had given her a larger repositioning bar, but there were probably multiple reasons that she got rid of it. One might be it was too big. Another might be it was too medical. Another one, it might have been in the way for making the bed. And then the other reason is she might not need it anymore because she got an automatic bed that we positioned. And then for bathing, again, that rug was pretty hazardous because it was slippy. The problem with that tan rug is it was the same color as the tub. So you know she picked that rug intentionally because it matched the tub. So honestly, there's not much we can do about that rug issue. Maybe there is, maybe somebody can do some guided pursuing and motivational interviewing to address the rug issues. And the same thing with the one by the sink. It does not have a firm back. So we want a gripper back rug, low pile, beveled edges. And unfortunately, those kinds of rugs aren't usually that pretty. So rugs are a major issue in the bathroom and in the entryways. I think the tub bench that she has is adequate for what she's doing. She did not have any trouble sitting on it. And then again, it's really important to actually do a demonstration of how to do it properly and then have them do return demonstration. A good rule of thumb is to demonstrate 3 times and then return demonstration 3 times. I think I talked about the stairs. All right. So when I write up the home eval report, I really capture the strengths that she's doing well, really acknowledge what they're doing well, because that reinforces the good things and then some of the challenges. I don't know what to do about the dogs. I left them in the video because I wanted it to be authentic. When you do home evaluations or other people do them, there are going to be dogs around. And so that would be another conversation to have to figure out how to enhance the safety. The good thing about the triangle walker is when the walker goes first, the dogs kind of scoot out of the way, but they still do get underfoot, as you can see. I would also recommend a handrail towards the back of the tub. I'm not 100% convinced that those handrails that are attached to the tub are safest and stable. So I do like the ones that screw into studs in the walls better. And then another handrail in the downstairs shower. That one's a little bit harder to install because you have to go through tile. And I'll actually mark on the wall where I want it for contractors or construction workers. And then a raised toilet, an actual raised toilet would be better. It won't work if I recommend a raised toilet seat because she does not want it because urine sticks to the inside of the hole of the raised toilet seat. So it would be useless to recommend a raised toilet seat. She really does need a higher toilet itself. And all interprofessional team members can utilize that report. And again, it's really important to do those educational interventions simultaneously during that home assessment. And I use 5 different strategies from the Ecology Human Performance Model. Create, promote is health promotion, and that might be education, for example, the connection between hydration and balance. And then establish, restore. This is establishing new skills or restoring old skills that maybe were lost from an illness. So for example, lower extremity home exercise program that fits into their normal habits and routines would be really beneficial. And a lot of the team members can collaborate on that. I like to go to a physical therapist for collaboration in particular for those lower extremity home exercise programs. Maintain. We want to reinforce the strategies that our clients are already doing, such as Virginia having rails by the toilet and then 2 rails going down the stairs. Then we did modify, adapt, and in this case, we modified ways to transport food items while Virginia kept her hands on the walker. And then, of course, we want to do some prevention. We actually do prevention of falls, such as removing or repositioning tripping hazards, like how Andrew moved the chair in Virginia's living room. The rugs are a little bit trickier to address because they're pretty. And I just read an article from the American Occupational Therapy Association about diversity, equity, inclusion. And they use these rugs in a home eval as a specific example to be client-centered and respectful of their wishes. So it was interesting how that article aligned with the rug issue. But they have a right to have the beautiful rugs. They're important to people. So we have to address those very sensitively. And again, we want to make sure that we give them a sense of control. So we always give them choices. They feel a loss of control because a lot of them are losing loved ones. You know, dad just lost another teacher friend yesterday or the day before, and it just kind of feels like he's losing control. And then they lose control because of all the age-related changes in encountering. So the best thing we can do is really give them choices. How would you like to start this task? Or I have two suggestions in this room. Which one would you rather use? Or I would like to recommend, what changes would you like to make to that recommendation? So there's always that collaborative tone that gives them a sense of control over their life. I'm pretty loud and assertive and on a mission to eliminate the word compliance from all of our vocabulary. So please don't use this word. It is a bad word. Sorry to be so blunt, but it suggests a hierarchy authority over the client. Instead, it's better to use the word adherence or ability to follow through, because it shows a more collaborative tone. So we do want to use those words. And if they're having trouble adhering to some recommendation, it's up to the provider to figure out what that barrier is and then help navigate or collaborate to overcome that barrier. All education materials should be written with images taken from the actual evaluation, because most people only don't process auditory information. I have on here other resources. The CDC has a toolkit for stopping elderly accidents, deaths, and injuries. And all of these items are in that toolkit. So checklists, screenings, education materials, it's really quite wonderful. Here's some more. I'm kind of running out of time. So I'm going to get to the end. Interprofessional team is needed for preventing falls. Multiple team members can do and conduct pre-home screening, home evaluations, and accurate assessment, and offers the opportunity for intervention in a natural setting. And the home eval and safe mobility intervention should be done concurrently. And I have 1 minute left. That was a lot of information to get through. I hope that was meaningful, and I hope you enjoyed those videos. And thank you again to Andrew and Virginia for helping that.